مش واضح أو
تمام.
خبروني يعني.
تمام.
كم عددكم؟ كم العدد؟
احنا 34 هسه بجوز دقيقتين بنكتمل ان شاء الله. اللي حاليا موجود 28.
معانا limited time ولا يعني 40
لا
دقيقة؟
لا 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 على قد ما بدنا دكتور.
اوكي. قديش حكيت لي العدد؟ 28.
احنا الفل 34 دكتور.
طيب ماشي. I think I will go ahead and start لأنه
تمام دكتور. هسه شوي
مش
مش لاقي العدد يكتمل بس بجوز عبين ما يفتح يعني.
ماشي fine. طيب ماشي. If you have questions, write them down or make notations. You can ask me at the end of the lecture. Make sure you have these slides. هم شوية a little bit different from last year's slides. So if you don't have them, I can send them to you.
I think we got them from the previous groups.
ماشي.
تمام.
So today's topic is about headache disorders and facial pain. This is a big topic, and actually headache is the most common complaints patients have in the neuro outpatient clinic. It's a symptom that is commonly encountered in everyday practice. So it's very important that everyone has an idea about the different types of the headache, in how to diagnose them, how to exclude serious causes or secondary causes, or what's called red flags for headache disorders. Here I have the basic outline of this talk. So first we will start with the most recent classification of headache disorders and facial pain by the International Headache Society. And then we'll go over the red flags of headache disorders, secondary causes mainly. And we will describe the clinical features of common headache disorders and just a review of the basic treatment guidelines for different headache disorders and facial pain. So this is the most recent classification of headache disorders based on the International Headache Society. They simply divide headaches into primary headache, where you don't have an underlying cause. This includes migraine headache, tension type headache, and cluster headache. We have secondary headache disorders where there is underlying cause that you have to treat and not only cover the pain. And this includes headache attributed to trauma or injury to the head or neck, headache attributed to cranial or cervical vascular disease, the stroke, for example, subdural hematoma, epidural hematoma, or even subarachnoid hemorrhage. All of that examples for vascular disease that can cause headache. We have headache attributed to non-vascular intracranial disorder like high or low CSF pressure, and headache attributed to infections like meningitis or encephalitis. Last thing is neuropathies and facial pains, and this includes the trigeminal neuralgia, occipital neuralgia, and glossopharyngeal neuralgia. So today I will go over or spend some time discussing the different types of primary headache, all of them actually, primary headache disorders, the migraine, the tension, and cluster. I will talk about two examples of headache disorders, including the giant cell arteritis and the idiopathic intracranial hypertension. And the last thing will be trigeminal neuralgia, an example of neuropathies.
قطع الصوت ولا بس عندي؟
Okay, that's fine. I can
yeah,
I can hear you now. Yeah. So the differentiation between primary and secondary causes of headache is critical as it dictates the diagnostic approach and guided treatment and the prognosis. And the most important step to differentiate between the primary and the secondary headache is the history. So history is the key whenever you evaluate an inpatient with headache. You take a detailed, thorough history from the patient, and in most of the cases, you will find the answer in the history. So we ask about the location where the pain is, the duration, how long does it last, the nature, whether throbbing, pressing, tightening in nature, the severity, whether mild, moderate, or severe, any other associated symptoms with the headache, the nausea, the vomiting, phono, photosensitivity, any exacerbating or relieving factors, what makes it worse or better. Family history is also important. For migraine patients, for example, you will have a family member with migraine. And in the physical exam part, of course, the full neurological examination, we look for signs of focal neuronal dysfunction or focal neurological dysfunction, and this will suggest a secondary cause, like intracranial pathology. If you find a weakness, for example, a weak arm or a weak leg. So focal neurological deficits should raise a concern for secondary causes of headache. Okay, next. So you take a detailed history and in your mind, you screen for red flags associated with secondary serious causes of headache, and those are summarized into SNOOP. So the first is for systemic signs and symptoms, including the fever, meningismus. Meningismus means signs of meningeal irritation or meningeal signs. Vomiting or immunocompromised state, all of that can suggest CNS infection, for example, meningitis or encephalitis. We also inquire about medication like anticoagulation, any blood thinner in general. With a new onset headache, that should raise a concern for secondary causes of headache like intracranial bleed. So you always ask about medication. N is for neurological symptoms like altered mental status, weakness, or seizure, all of that suggests intracranial pathology. O is for the onset, abrupt and severe, and we have an example for the second subarachnoid hemorrhage, which is usually the headache associated with the subarachnoid hemorrhage, is described as the worst headache in life. If the headache is associated with sneezing or straining, it suggests posterior fossa pathology. The other O is for the age, older age at onset, more than 60, and some books 65. This should also raise the concern for secondary causes of headache. P is progression of the headache, if there is any worsening of the severity or the frequency of the headache. Like, for example, if you have a patient who is a known case of migraine headache, since the age of 18, and at the age of 40, he started to have a different character or increase in the frequency or the severity of the headache, then you have to think about secondary causes of headache. So the first thing is the primary headache disorders, and we'll discuss the migraine first. The migraine is divided into migraine with aura, which is the classic migraine, migraine without aura, which is the common migraine, and we have something else called the chronic migraine, and I will show you the definition of chronic migraine in a few minutes. So we have theories. I don't think you need to know that in details, but we have a vascular theory. This is the most popular one and old one. We all know that vasodilators can cause pain, and vasoconstrictors, they relieve the pain. More recently, we have the neurovascular theory. Some neuropeptide like calcitonin gene-related peptide lead to vascular changes in vasodilation, and that's and they are thought to be involved in the mechanism or pathophysiology of the migraine. And actually, that was very important in terms of the drug development. They found that CGRP or calcitonin gene-related peptide inhibitors, they actually help with the migraine pain. So some theories regarding the pathophysiology of the migraine pain. The common migraine is defined, again, migraine is an example of the primary headache disorder. This is defined as recurrent headache disorders manifesting in attacks lasting between 4 to 72 hours. So few hours to few days, maximum 3 days in duration. The migraine is usually unilateral, so on one side. That's around 70% of the patients. 1/3 of them, they will have bilateral pain. So bilateral involvement is not totally against migraine. You will see bilateral pain, especially in young age group. The most common form of migraine is usually unilateral. And it can switch sides, so sometimes on the right and sometimes on the left. It's a pulsating or throbbing in nature, and it's moderate to severe in intensity. So migraine is not mild. Usually aggravated by routine physical activity and associated with nausea, vomiting, phono or photophobia. So the light or the noise can exacerbate the symptoms. The classic migraine is the typical migraine pain, but preceded by a complex of neurological symptoms. They are called auras, and they usually happen before the headache and may continue into the headache phase. Again, those symptoms are unilateral, so on one side, and the key is that all the auras are fully reversible. So patients are okay in between migraine attacks. They go back to their baseline. Each individual aura lasts between 5 to 60 minutes. And the most common form of the aura is actually visual. So patients report flashes of light, scotoma, visual field effect, these zigzag lines, a blurry vision just before the migraine pain. It may continue into the headache phase. Visual auras are the most common type in 90% of classic migraine patients. Next in the frequency is the sensory disturbances. So some patients report even sensory symptoms on one side preceding the migraine. Can be even motor. We call them hemiplegic migraine. So different manifestation of the aura preceding the migraine, but the most common form of aura is actually visual. Just to remind you of the 4 phases of the migraine, we have a prodromal phase. This can begin hours or days before the migraine. Patients report fatigue, difficulty concentrating, photosensitivity, blurry vision, and this is followed by the aura again. We mentioned it lasts between 5 to 60 minutes in duration, and then followed by the pain of the migraine, few hours to few days, maximum 72 hours in duration. In some, they have the postdromal phase, again, 1 to 2 days of changes in the mood, fatigue again. This is called the postdromal phase. The chronic migraine is defined as headache occurring on 15 or more days per month for more than 3 months. So we ask the patients, how many days of migraine pain or headache do you have in a month? If it's 15 or more, that's defined as chronic migraine. And this is important in terms of treatment. So the frequency is very important to establish not only the severity. If the patient has very frequent migraine pain, the treatment would be different. So how do we treat migraine? 2 lines. The first one is acute abortive medications at the time of the pain to ease the migraine pain. And this can be migraine-specific medications or migraine non-specific. The migraine non-specific, a simple over-the-counter pain medication like non-steroidal anti-inflammatory drugs. It can be triptans, and the triptans are they are a family of medications or drugs designed specifically for migraine pain. Very potent vasoconstrictor. They can help to ease the migraine pain. They have their own contraindications. You don't really need to know how we give triptans, what's the dose, what different types, side effects. Again, it's just an overview of the basic things. Basic things are simple over-the-counter medication. If it doesn't work, you can use sumatriptan, naratriptan, any drug from the triptan family. Again, if the headache is a frequent disabling, we can use preventive or prophylactic medication to decrease the frequency, the severity, and the duration of the migraine pain in the future. We have options, and those include the tricyclic antidepressant medication like the amitriptyline, beta blockers like the propranolol, and the anti-seizure medication like the topiramate, valproate. Botox injection or botulism toxin injection is another option, FDA approved for the prevention of migraine. We already mentioned the CGRP inhibitors too. Okay, so next, another example of the tension type headache. An example of the primary headache disorders is the tension type headache. I'll just need 1 minute. Okay, so back to tension type headache, defined as infrequent, frequent, or chronic episodes of headache, typically bilateral, so on both sides, pressing or tightening in nature, mild to moderate in intensity, lasting a few minutes to a few days. The pain does not worsen with routine physical activity and is not usually associated with nausea, although phono and photophobia can happen. So this is different from the migraine. A migraine usually unilateral and tension is bilateral. Migraine is throbbing or pulsatile and tension is pressing or tightening. Migraine is moderate to severe and tension is mild to moderate. They both last hours to days. Migraine is usually exacerbated by physical activity and associated with those symptoms. Phobia, nausea, and vomiting. And tension type headache is not. Okay. Okay, so treatment, again, 2 lines, acute abortive simple over-the-counter pain medication. If the tension headache is a frequent and disabling, preventive prophylactic options include anti-seizure medication like the topiramate, tricyclic antidepressant like the amitriptyline, and we have the muscle relaxant too. So you can choose one of these options. Last example of a primary headache disorder is the cluster headache. And the cluster headache is defined as attacks of very, very, very severe pain, excruciating pain, used to be called suicidal pain. It's a strictly unilateral, so almost always in one side, and it does not switch sides. Migraine is unilateral in most of the cases, but can switch sides. Cluster headache is always in one side. Most common location is orbital or supraorbital or temporal region. It lasts 15 to 180 minutes, so a few minutes to 3 hours in duration, so shorter in comparison to the migraine and the tension headache. The frequency is variable, so from once every other day to multiple 8 times per day. So it's shorter in duration and more frequent. The pain is associated with ipsilateral conjunctival injection, so eye redness, lacrimation, nasal congestion, rhinorrhea. They can have facial sweating, miosis or ptosis, or even eyelid edema. So cluster headache is associated with other symptoms, mainly autonomic symptoms. If you have a patient with strictly unilateral pain that is orbital or supraorbital, frequent attacks lasting a few minutes and a few hours, and it is associated with autonomic manifestation listed here in this slide, then the top of your differential diagnosis must be cluster headache. As you can see in this picture, we have a cluster here of a frequent attacks of short-lasting headache, followed by a remission period, and this remission period can last between months or years sometimes, followed by another cluster of very frequent attacks of short-lasting headache. And you can see clearly in this picture, this patient has rhinorrhea, eye redness, some ptosis, and miosis. So remember, autonomic symptoms mainly in cluster headache, provoked by alcohol and histamine, nitroglycerin again because it's vasodilator. For unknown reason, men are usually more affected than women. How can we treat cluster headache? Acute abortive with oxygen therapy inhaled at 100% for 15 minutes. This is actually diagnostic and therapeutic at the same time. If you have high index of suspicion for a cluster and you send the patient to the emergency room, they take oxygen therapy, they will improve. And this is diagnostic and therapeutic at the same time. You can also use triptan and ergotamine. Both examples of very potent vasoconstrictors can be used for migraine and cluster headache. For prevention of further clusters of these very severe excruciating pain, you can use the calcium channel blockers like verapamil, lithium, or the seizure medication like topiramate or valproate. So those are the options for preventing or as a prophylactic treatment for a cluster headache. This is a very nice table summarizing everything we have talked about, mainly the primary headache disorders, the migraine, the tension, and the cluster. The migraine unilateral, most of the cases, tension bilateral, and cluster almost always one side. It does not switch side. Migraine, moderate to severe, tension is mild, cluster very severe. The duration for migraine and tension, minutes, days to hours, and cluster is shorter. 15 minutes to 3 hours. Migraine is associated with some symptoms, phonophobia, nausea, vomiting. Tension can be, may or may not be associated with those symptoms. The cluster headache is associated with different type of symptoms, mainly autonomic manifestation. Okay, so this is a very nice table summarizing everything about the primary headache disorder. Next, as an example of the secondary causes of headache, vascular cause, it's called temporal arteritis or giant cell arteritis. So it's a systemic inflammatory vasculitis. It's a form of vasculitis of unknown etiology affecting the elderly more. This will result in a wide variety of systemic and neurologic and ophthalmologic complications, not only the headache. There is something else going on with the headache. So it can affect large, medium, or small arteries, but particularly the superficial temporal artery, and that's why it's called temporal arteritis. Again, affecting elderly, so more than 60, and the incidence will increase with age. The female to male ratio is 2 to 1, so more common in females. What do they have, or how do they manifest? So headache, again, non-specific features of the headache. There is a strong association with a condition called polymyalgia rheumatica, PMR, multiple joint stiffness and pain. They also report fatigue, jaw claudication, which is a jaw pain with chewing or eating or talking, and also fever. So some systemic manifestation. Around 50% of the patient with giant cell arteritis, they also have visual symptoms. And this can be either transient, intermittent, but if left untreated, it can lead to permanent visual loss, irreversible vision loss. The most common cause of the vision loss in this condition, the giant cell arteritis, is the anterior ischemic optic neuropathy due to vasculitis affecting the posterior ciliary artery. So remember, for the clinical manifestation of giant cell arteritis, you have the headache, but you also have some systemic manifestation, and you have ophthalmologic or visual symptoms too. In the physical exam part, we have clues. So there is something called superficial temporal artery tenderness. So whenever you press on the temporal artery in the temporal head region, you will induce the pain. So there is pain, there is tenderness. And we also look in the physical examination for signs of optic neuropathy, including decreased visual acuity, the color vision, and the visual field effect by the so optic neuropathy is also common in this disease. Diagnostic tests, we have the blood test first, the ESR and C-reactive. Most of them, most of the cases, they will be elevated. Around 7 to 20%, they have a normal ESR C-reactive, but that does not rule out the condition. The gold standard really for the diagnosis of this form of vasculitis is the biopsy. So you need superficial temporal artery biopsy to look for the some characteristic changes, and this is a slide showing the pathophysiology. So there is a narrowing of the lumen here in the middle. This is an artery affected by vasculitis. There is inflammatory cells, a lymphocyte, and the giant cells accumulating around the internal elastic membrane. And thickening of the tunica media causing this narrowing of the lumen of the vessel. Another picture just to compare the normal healthy artery with an artery affected by the vasculitis or giant cell arteritis, superficial temporal artery. So you have here the narrowing of the lumen of the vessel secondary to the tunica media thickening, and you have those inflammatory cells, the lymphocyte, and the giant cells on the blue ones, maybe purplish one, accumulating around the internal elastic membrane. So you need really a biopsy to confirm your diagnosis. The result of this biopsy will take time, between a week or 2 weeks. And because the vision loss can happen really rapidly and irreversibly in giant cell arteritis, you don't really have to wait for the result of the biopsy. If you have high index of suspicion, you have to treat. You arrange for the biopsy, you do the biopsy, but treat in the most universally accepted treatment for giant cell arteritis is high-dose steroid therapy, and that will not confound the biopsy result because most of the characteristic histological changes will still be seen for a few weeks even after the initiation of the treatment. So if you have an elderly patient with headache and other associated symptoms, mainly systemic, the fever, fatigue, jaw claudication, they have PMR or polymyalgia rheumatica, they have some visual symptoms, transient, unilateral, on and off. You do a physical exam and you find temporal artery tenderness or signs of optic neuropathy. You send for ESR and C-reactive protein. So you think giant cell arteritis based on that presentation and physical exam. You have to think about giant cell arteritis. That's the top of your differential diagnosis. The age is a big red flag in this condition. So remember, the red flags, the age was one of them. In elderly patient, you have to be very careful before diagnosing an elderly patient with a migraine or a cluster or tension headache. You have to dig more and find it, try to go over the red flags to make sure they don't have the serious causes or secondary causes of headache. So in this condition, the age is a red flag. The systemic sign and symptoms also is another flag. So you have this suspicion of secondary causes based on these red flags, the presentation, physical exam finding with the temporal tenderness and the optic neuropathy findings. So you have to send for the blood test and they come back high, ESR and C-reactive. You immediately arrange for biopsy, but you also treat with a steroid to preserve the vision. Okay, so next an example of the neuropathies. This is the trigeminal neuralgia defined as recurrent paroxysm of unilateral facial pain in the distribution of the trigeminal nerve. And pain has to have all of the following. It's very short, lasting between seconds to 2 minutes maximum. It's very severe in intensity. It's described as shooting pain or shock-like or stabbing pain. So paroxysmal, very severe, lasting for a few seconds to 2 minutes in duration. It's usually precipitated by stimuli, so it's not uncommon for patients to report this pain or facial pain whenever they brush their teeth, whenever they put makeup or shave. So sensory stimuli can induce this pain. And you can do that actually in the clinic. You can press in certain areas. We call them trigger zone, just behind the ear sometimes, and this can induce the trigeminal neuralgia pain. Causes, usually idiopathic, so we don't have a cause, but we like to screen for secondary causes, like a space-occupying lesion or a tumor in contact with the trigeminal nerve or compressing the trigeminal nerve, as you can see in the MRI in this picture. Sometimes there is a vascular compression on the trigeminal root. We like to do MRA too. In young female patients or in the appropriate clinical context, not in all patients, sometimes we think about multiple sclerosis. Multiple sclerosis is an example of the central demyelinating disease. Usually affects the young patients. Females are more likely to be affected by multiple sclerosis than males, so mainly young patients. So MS plaques at the trigeminal root entry zone or in the bones can cause trigeminal neuralgia. So remember, trigeminal neuralgia usually it's idiopathic, but if you have a cause, it can be a space-occupying lesion, a tumor, for example, a vascular compression, or MS plaque. How do we treat trigeminal neuralgia? It's mainly medical with seizure medication, carbamazepine, gabapentin, topiramate, lamotrigine. If they fail the medical option, then we have some surgical options. And this includes microvascular decompression or repositioning of the artery, compressing the trigeminal nerve. We have the radiofrequency thermal lesioning, so damaging the trigeminal nerve to ease the pain. And brain stereotactic radiosurgery or the gamma knife. The gamma knife is a specific device designed to deliver a beam of radiation to the trigeminal nerve, again damaging the nerve to ease the pain. But we only use the surgical options if patients fail the medical options. The last example is an example actually of the secondary causes of headache. Disorder of increased intracranial pressure. It's called pseudotumor cerebri syndrome, and this syndrome had a lot of names in its history. It used to be called benign intracranial hypertension, and then they changed the name because they found it's not really benign. It can have serious complication. So they changed the name to idiopathic intracranial hypertension. It's a disorder of unknown etiology, predominantly affecting the obese women of childbearing age. The primary problem is a chronically elevated intracranial pressure. And the most common neuro manifestation is the papilledema, which can cause a secondary progressive optic atrophy, vision loss, and sometimes blindness. And that's why it's not really benign. The etiology is not known, but we screen for secondary causes, like some medications, antibiotics, doxycycline, vitamin A, obstruction to the cerebral venous outflow, some endocrine disorders, obstructive sleep apnea, head trauma. If you don't find a cause, it's called idiopathic intracranial hypertension. In most of the cases, we actually do not have an underlying cause. It's idiopathic. So patients with idiopathic intracranial hypertension, they will have signs and symptoms of increased intracranial pressure. Most of them, 80 to 90% of the patients will have headache. Again, no distinguishing features, but some have a headache whenever they lie down or nocturnal. They also report transient visual obscuration or visual symptoms, brief episodes, so intermittent. This can be unilateral or bilateral. And again, if this condition is left untreated, it can lead to vision loss. So any transient visual symptoms in the form of blackout or whiteout or a blurry vision, cloudy or foggy vision, they describe it, in one or both eyes for a few minutes, seconds, or minutes. This also can happen and can be reported in patients with the idiopathic intracranial hypertension. They can have double vision or diplopia, often binocular, which means that patients will see double only when they view things from both eyes simultaneously. If they cover one eye, they don't see double. That's called binocular diplopia. And this is actually secondary to involvement of the sixth nerve, abducens nerve, secondary to increase in the intracranial pressure. Pulsatile tinnitus is another manifestation or presentation for the intracranial hypertension. So young, female, obese, she has headache. Non-specific feature may be more with lying down. They have she has a transient visual obscuration or blurry vision or blacking out of the vision in one eye or both. She also reports double vision or tinnitus. Then you have to think about idiopathic intracranial hypertension. Next step is to look into their eyes. Vision evaluation or optic nerve function assessment is part of the general neuro exam. It's part of the cranial nerve exam. And we routinely do fundoscopy for all patients with headache. Whenever you see a patient with headache, always do fundoscopy to rule out papilledema or optic disc swelling secondary to increased intracranial pressure. So patients with idiopathic intracranial hypertension, they will have papilledema or optic disc swelling secondary to this increase in the intracranial pressure, and we look for that by the fundoscopy. We also examine the visual acuity in each eye, the visual field for visual field defect, and ocular motility examination to look for sixth nerve palsy. So remember fundoscopy for all patients with headache. Okay, so young, female, obese, signs and symptoms of increased intracranial pressure. You look into their eyes, you find papilledema or optic disc swelling secondary to increased intracranial pressure. The next step, you have to rule out a tumor, a space-occupying lesion causing this increase in the intracranial pressure. And that's why we do MRI brain. And we add MRV to exclude a venous sinus thrombosis, which can cause increase in the intracranial pressure. In this condition, it's called idiopathic. So there is no space-occupying lesion. There are signs or symptoms of increased intracranial pressure, but there is no tumor. That's why we call it pseudotumor cerebri syndrome. So normal brain MRI and MRV. There are several possible radio signs. I don't think you need really to know them. In A, you have empty sella torsica. In B, we have a flattening of the back of the globe. In C, we have tortuosity of the optic nerve. And in D, we have narrowing of the transverse sinus. So those suggest just increase in intracranial pressure. They are not diagnostic for this condition. Okay, so we did the MRI brain. We did not find a pathology. There is no tumor. And we need to confirm the diagnosis, and we do lumbar puncture. So LP to measure the opening pressure. We have this device in this picture is called manometer. We measure the opening pressure. If it's more than 250, then that's diagnostic. We also send the CSF for analysis. We look for the RBC and the white BC to rule out CNS infection, meningitis, or encephalitis. So again, to diagnose this condition, you have to have babble edema, a normal level of consciousness, a normal image, brain image, normal MRI, except for the signs that we just mentioned, a lumbar puncture with opening pressure measurement, a high opening pressure, and a normal CSF composition. Normal composition means there is no white BC in the CSF, there is no infection, there is no meningitis, there is no encephalitis. Okay, how do we treat? The treatment goal in patients with idiopathic intracranial hypertension is to preserve the vision while managing the intracranial pressure increase. So we do optic nerve function assessment frequently. We recommend weight loss for obese patients. We give some medications like carbonic anhydrase inhibitor, example is acetazolamide, benzamide diamox, to lower the intracranial pressure. We have other options like the topiramate. It has the same carbonic anhydrase inhibitor mechanism, and it can help actually with the weight loss too. So it's beneficial, the topiramate. Diuretics is another option, less likely to be used though, it's not popular. If patients fail to respond to the medical options, they continue to be symptomatic, babble edema is worsening, then we have surgical options. You can do optic nerve sheath fenestration, so you release the pressure on the optic nerve, or you can do CSF diversion or shunting, lumbar-peritoneal shunt or ventricular-peritoneal shunt. So that's how you treat idiopathic intracranial hypertension, medical and surgical options. This is my last slide to summarize. Headache is very common, maybe primary or secondary. Secondary, potentially life-threatening condition should always be considered and screen for that, first with the history and then screen for red flag with the SNOOP. It's very important to differentiate the primary and secondary headache because that will change your approach in the treatment and change also the prognosis. That is it. This is my last slide. Do you have any question?
يعطيك العافية دكتور.
الله يعافيك. If you have questions, after reading this slides of this lecture or studying it, you can find me.